Good morning. Happy Monday. I have Neuro Coffee in hand and it is perfect. All right, a very busy Monday. First item is a little bit of housekeeping in regards to the intensive. I'm getting a lot of questions about the next intensive since this is the new year. Looks like it's going to be somewhere around the middle of March. Start planning that. I should have the date locked down actually this week, so I'll probably announce that. If you're interested in the intensive, the first group that gets dibs on application is on my email list. So if you go to the end of any blog on billhartmanpt.com, go to the end of the blog there. There's a place where you can get signed up for that list, so you get first dibs. So again, intensive somewhere middle March, probably announced this week. Okay, digging into today's Q&A. This is with Victor. We've talked to Victor before. Victor's a chiropractor, and he's running into a couple of presentations that are very, very similar. Patients with a very flat appearance to the upper back, always complaining about lower cervical, lower neck issues. This tends to be a situation where we have a limitation in the dorsal-rostral area. So if we look at Alfred here, it's going to be this area between the scapula. Upper DR is going to be here, and that's going to affect the lower cervical spine position quite a bit. The compression is going to take away your rotations because you basically eliminated any gradient that is available to allow those turns to take place. And so we talk about a treatment sequence actually that he can utilize to actually restore that gradient and then be able to apply his typical manual therapies that he would do as a chiropractor. So this is a very useful discussion for those of you that are questioning like okay, what is the sequence of events that we're using to resolve these issues. This will be a very, very good one. If you'd like to participate in a 15-minute consultation just like Victor, please go to askbillhartman@gmail.com, askbillhartman@gmail.com. Please put 15-minute consultation in the subject line so I don't delete it, and we will arrange that at our mutual convenience. Everybody have an outstanding Monday, and I will see you tomorrow. Clock has started. We are rolling. Go ahead.
All right. So I've run into a lot of particularly females in clinic so far with a lot of upper trap tension, neck tension, of course, that goes along with that.
Yep.
And their shape of their thorax seems to be this wide shoulder, flat T-spine kind of a archetype, so to speak. And I interpret that as dorsal-rostral compression.
Yep.
But I just wanted to hear any of your thoughts of other things to consider. Of course, restoring dynamic ISA would be, I would assume, step one. But yeah, I wanted to hear your thoughts.
Well, let's talk about the end representation first, so we have an understanding of that, and then we can sort of, progressively strip these things away. So if you've got somebody that has especially limited rotation, which I'm sure you're evaluating it in some way, shape, or form. So if you've got an upper DR that is compressed, so people will complain about, upper trapezius, lower cervical spine kind of stuff. They'll feel stiff, like, they're the people that try to back out of their driveway, and can't turn their head, that kind of thing. So hopefully they have the cameras, in their car. Where they can actually see themselves back out of the car. But if you've got upper DR compression, then you've got a lower cervical spine that is in an IR force producing position. So it is going to be compressed as well. And that is going to take away the turns. So it doesn't mean they can't turn their head at all, but it's going to be upper cervical spine that's going to be producing that type of a rotation. Okay. Now, if you were to apply some form of manual therapy, the goal would be to restore the expansive capability of those segments to allow them to start to turn again. So this comes down to, okay, what are going to be your choices? Because you do manual therapy as part of your gig, right? And so now you're going to have to make a really well-educated decision as to what approach you're going to take with this. Because if you've got upper DR compression, I got news for you. You got AP compression throughout under most circumstances. These are wide ISA people?
The couple that I've taken the time to assess, yes, they are.
Yeah. Okay. So number one, limited turning capability to begin with based on archetype. Okay. They're going to initiate after the diaphragmatic compensatory strategy to take the breath in, you're going to see DR compression. So right away, you know where you're going to have to strip away, but they're going to lose both. So they're going to lose ERs and IRs. They're going to use orientations to create their internal rotation. And so again, this is why they start to get that lower cervical spine stuff, because the thorax is anteriorly oriented and the spine is pushing downward, like I said, in that IR. Because remember, IR is down, ER is up under these circumstances. And so all they're doing is putting downward pressure. You don't want to look at this in isolation. I would encourage you to consider the entire axial scope. Huh?
That you don't say.
Yeah. Well, just, occasionally, you can get symptomatic relief in isolation.
Right.
I'm okay with that. I'm okay with that. But you want to look at this from the broader viewpoint of like, okay, everything works together. Nothing works in isolation. And but again, ultimately, you're going to have to start thinking about, okay, this is going to end up being a situation where the DR and upper DR need expansion. So you restore the ER representation of the lower cervical spine, because that's where all the motion is, right?
Right. So let's say the couple that are wide, is there, I guess it's kind of a goofy question, some efficient manual therapy set up to have them in sideline to help with that?
Yes. Yeah. So have you ever seen the scapular decompression video on my YouTube channel?
Yes, where they're supine, I believe.
No, they're no, that's the depression you're thinking of.
Yes,
no, this is the side lying version where what you're gonna do is you're gonna bring the scap off the thorax, and then as you drive expansion, that's gonna help. You're literally manually creating the DR space to allow that to expand under those circumstances. That's a great place to start from a manual perspective. What you're lacking. So here's the thing. Have you manipulated yet?
Yes.
Okay. So you did like the T1 through 3 kind of stuff, and then the lower cervical, right?
Yeah, I'm a sucker for the thumb move.
Yeah, I understand. Everybody loves that one. But limited success.
It's actually, so I'll get a cavitation.
I'm not talking about that. I'm not talking about making noises. I'm talking about the restoration of turns.
Yeah, I didn't go back and reassess my.
Okay, you need to.
Right.
Here's my point. When you've got an AP compression and you're trying to restore turns, one of the limiting factors in the desired outcome, which is the restoration of those turns, is the fact that you don't have a big enough gradient. Okay. So if you've got somebody that's AP compressed, listen, if you got somebody that's AP compressed, you can create the cavitation at the joint level, but you might not get the change in muscle orientation that you need to create the joint movement. Okay. So here's what I would suggest. You do activities or manual therapies to create the expansive strategy first, then deliver your manual therapy. Now you've got a bigger gradient. So when you manipulate, you're creating an IR force. If you've got a position of the spine that's already IR'd, you might not have a big enough gradient to make the muscle change. Okay. Anytime, like if you do, you're chiro, right?
Mm-hmm.
Okay. You do ART?
Yes.
Okay. So here you go. So you do your lower cervical, upper thoracic, ART stuff to create the expansion. So you're going to be going like, you go upper trap, you go rhomboid, you go serratus posterior superior, right? All those, you get all of those. You do your lower cervical stuff as well with the turns. So you're going to do that, then deliver your high velocity stuff, and you're going to get a much better response. You'll always get a better response with a better gradient. And it's not just the cavitations I'm talking about. I'm talking about the muscle orientation change, because when you manipulate, you create an IR force on one side and the ER on the other side. You will get a reorientation of muscle, and you will get a bigger turn. Do you see how it works?
Yes, that totally makes sense. I've been thinking a lot about the gradient aspect the last couple of weeks, but that's a whole
Sometimes you have to create the gradient first, and then all of the manual stuff that like again, the deeper manual stuff that it would be skeletal in its response works so much better. But you've got to give yourself an opportunity. Again, no gradient, no change.
Yeah, it's simple enough. That makes total sense.
It sounds simple, but now you're working with humans, right?
Yes, yeah. There's that part.